Welcome to the show discussing problems and issues of health for Dr. Alcena. For this segment, I'm going to continue to talk about diabetes mellitus. When I left off last week, I was getting into the treatment of diabetes mellitus using medication by mouth. Let me go over the statistics again for those of you who may not have seen the previous show. This is show number 7. Across the world, 425 million people suffer from diabetes. 22 million of those have type 1 diabetes, okay? That's across the world. And 10% of women across the world suffer from gestational diabetes. In this country, the United States of America, 30.3 million people have type 2 diabetes, and 1.25 million people have type 1 diabetes, and 130,000 women every year develop gestational diabetes while they're pregnant. So these are the stats. Okay, now, but one has to understand, how do you go about deciding when to treat someone for diabetes? Well, the main key really is pretty simple. The person becomes hyperglycemic. Just because an individual doesn't have hyperglycemia, that doesn't mean they don't have diabetes, okay? It is completely false to introduce this notion in the mind of the public, and for that matter, to infiltrate the medical community with the concept of prediabetes. It doesn't exist, truly. The reason why it doesn't exist is because when one looks at the reality of it, the science of it, by the time someone's blood sugar goes up, who was supposed to have pre-diabetes, they have already lost 80% of the beta cell functions of the pancreas, 80%. And they have been, in fact, diabetic for at least 10 years, suffering from many symptoms of diabetes. They didn't even know about it because the blood sugar was not elevated when they measured it. If you really want to know if somebody having those symptoms, that they have diabetes or not, that is dormant, that is they're not hyperglycemic, you do a glucose tolerance test. There's a 3-hour glucose tolerance test. There's a 5-hour glucose tolerance test. Those are complicated stuff. I'm not going to detail to you how the tests are done. That's really the key. Just because somebody's fasting blood sugar is normal, and they're having tingling in the legs, numbness, also problem with the eyes, the whole host of problem with the urinary bladder, etc. Doesn't necessarily mean they're not diabetic. You have not challenged them. If you were to challenge them, then you would know that they're in fact diabetes. Let me give you a classic example. Somebody who's having all these symptoms, for whatever reason, let's say they show up in the emergency room with an asthmatic attack, acute asthmatic attack. Well, one of the key ways you're going to treat the acute asthmatic attack, other than giving them bronchodilator, is give them a large dose of steroid acutely. Well, as soon as I get that steroid, I can guarantee you within a couple of hours or so, if you were to check the blood sugar, it's going to be very high. That's diabetes. That individual is diabetic, period. Okay? On top of that, the fact that you're going to give them likely a dose of adrenaline as well as part of the treatment for the acute asthma attack, that's also going to cause the blood sugar to go up. Why? Because adrenaline is anti-insulin hormone. Okay? I mean, I don't want to academically bore you to tell you how ridiculous it is. And I use the word ridiculous in parentheses because there are some very well-known, respected people who are really pushing this notion. And I can guarantee you, mark my word, years from now when I'm dead and gone, somebody's going to come right in with a different color than I am, with a different English accent than I am, going to say the same thing, and they're going to jump, oh my God. Whew. They're giving that individual credit for saying exactly what I'm saying to you right now. They're going to believe them because their skin color is better, different than I am. The accent is different than I am. Okay, this is the United States of America. the greatest country on earth, but unfortunately it is infiltrated deep into its DNA. It's a racial discrimination nonsense, which is very bad and very deadly, causing a lot of damage to people. Therefore then, mark my word for that. Believe me, mark my word, okay? So, therefore then, when someone blood sugar goes up, the first thing you would do to give them a diet that has low simple carbohydrate in it, because all simple carbohydrate by necessity must become developed into glucose once it gets into the body. Some of that becomes into fat. The rest of it we use for energy. That is one of the main causes of course, obesity. That's why the glucose, the liver turns it into fat. Some of it gets deposited throughout the soft tissues of the body. The rest of it infiltrates the liver because it stays in the liver, damages the liver. And the rest we use for energy because we don't need that much of it to use as energy, the excess. So that's the danger of simple carbohydrate. And the American diet is packed, loaded with simple carbohydrate, loaded. That's why obesity, of all the developed countries in the world, the U.S. have more obese people than any other developed country because of the diet that we face. That's the diet that we have to eat, especially the poor. The poorer you are, the worse the diet, because that's the only diet you can afford. You don't have time, not even if you had the time, you don't have the means with which to buy the quality food that you need to eat. In fact, most individuals in the minority community don't even have the transportation to take them to the big supermarket where they can buy the quality food on Fridays, on Saturdays, and what have you. They just don't have it. So they buy stuff that the little stores are selling in the community where they are. You have more little stores that are selling fast food in the minority community than any other business. So therefore, diet is the key. Then the next thing, of course, you're going to try to give them a oral agent, assuming the sugar was not showed up in a crisis. And I will be telling you what are the crises in diabetes mellitus. Believe me, I'll be telling you. But even before I get there, I have not paying enough time to type 1 diabetes. Type 1 diabetes is a deadly disease. It occurs in infant, children, adolescent, and what have you. And that's because the mechanism is the fact that the pancreas doesn't have function of beta cell. An autoimmune phenomena destroy the beta cells in the pancreas, so therefore the pancreas cannot produce the cells that are necessary to make insulin for them to use. So they must start using insulin, not oral agent, but insulin, since infancy if they come down with that. It's a very bad condition, but it is an autoimmune disease. And in this country, 1.25 million people are affected by it. Worldwide, it's 21 million. And these individuals must use insulin in order to survive. Diet and insulin. They also have to pay close attention to diet, because the worse the diet in terms of fat, I mean not fat, but sugar-containing stuff, simple carbohydrate, the higher the level of sugar will be and the more insulin they require, okay? So when you find someone who type 1 diabetes, it's an autoimmune disease. And remember, anyone with one autoimmune disease, if they live long enough, they're probably going to have 1 or 2 more autoimmune diseases during lifetime, because they have a body that's capable of producing autoimmune disease, 1. And they live long enough, they're going to wind up 1 or 2 more. That's just the way it is, okay? That's the reality of it. It's a very bad condition, and young people have to be adapted to it, and they've done a marvelous job in adapting to it. They grow up to become functioning adults, and so on and so forth, productive citizens of society. But they adapt to it, They survive, they play sport, they go to school, they become lawyers, they become physicians, they become teachers. There's no limit. Okay. Now, that having been said, now let's get back now to the treatment of type 2 diabetes. How do we wind up with this? I already told you. If the patient has functioning pancreas left, how do you tell? Well, you tell by just give them an oral agent. A diet, exercise, and oral agent. If the oral agent is able to bring the sugar down, that's your answer. They have sufficient beta cell left for the pancreas to release insulin once it is stimulated by them. The list is quite long. I have not had the need to use anything other than metformin, glyburide, lipicide, and Genuva. That's it. I haven't had no other oral agent, even though the list is quite long, and I have them listed in either one of those books for you. Because I'm a writer and I'm a teacher, I have to know these things, I have to explain them to people that I'm teaching. I have to write them, and I have to talk to them, lecture about them. But I have not had to use anything other than those 4 medications. The metformin is crucial, in particular in an individual that's obese. Because the metformin does not work at the level of the pancreas. What the metformin does is that it grabs the insulin that is being secreted by the pancreas and pushes it, forces it into the fat cell, and therefore entering the cell where they have to go to break down the sugar, to metabolize the sugar. Okay, so that's key. That's very important, because the longer the insulin that's being released by the pancreas sits in the circulation, as important as insulin is, insulin also has things that you don't want to know about. What are they? Well, insulin is an anabolic agent. The more insulin you have in your circulation, the more likely you have to have several major problems, including hunger. You want to eat more, you crave more for sugar-containing, glucose-containing food, like simple carbohydrate, which are bad for you, because that's what they needed. That's what you're craving for it. Now you understand why. And the more of those things you eat, the fatter you got. The fatter you got, the worse the diabetes become, the worse the obesity becomes. It's a vicious cycle. However, the metformin prevents that from occurring, because it grabs the insulin and pushes it and let the body use it. So that's crucial. In fact, we do use beta blocker, we do use metformin even in individuals that we're giving insulin to. And I'll tell you why when I get to talk about insulin. So that is crucial. And then, of course, the other medication, several of them, even though those I'm not using, they stimulate the pancreas to dump insulin into the circulation. Believe it or not, as important as insulin is, when it sits in your circulation, it can cause you to develop plaques in your arteries. How about that? Insulin has been proven scientifically to be atherogenic. How about that? That's incredibly important medication. When it sits too long in your circulation, it can cause you to develop plaques in your arteries too, because it has been documented by research done that it is in fact atherogenic. And on top of that, things that insulin can do to your electrolyte, which I'll be talking to you when I talk about the use of this incredibly important medication, which is insulin. So that's how the sugar goes up. We give them, the patients, the oral agent. It is only when they exhausted all the available oral agents, no matter how much we give, the quantity, no matter the quality, we still have problem bringing the sugar down. That's when the patient become insulin requiring patient. That means that there is no more left, no more beta cells left to be stimulated to release insulin. So therefore, that patient must be transferred from an oral agent to an insulin. That's one setting. But things are not that simple. That is very easy to do, nice and easy. It's not always that simple. Why so? Well, frequently, the patient will show up either in the doctor's office with symptoms that are so bad as it relates to hyperglycemic. The sugar is in the 400-500, and the patient is urinating like crazy because the sugar becomes like a diuretic. That's why the higher the sugar, the more urine, constantly running to the bathroom to urinate. Because the sugar, when it's high, it is basically serving also as a diuretic. So at that point, you have no choice. Even an individual who are insulin sensitive, you could still give them oral agent because there's still some left. Some happen to them, they have an infection. Or they get in contact with you, you have to treat them with steroid or whatever. Suddenly the sugar goes out of control, then you have nothing else you can do but to get them into the emergency room or admit them, give them insulin, bring the sugar down, and you try them again with oral agent. And frequently they respond because it was the stress associated with the infection of one type or another. It could be a viral infection acutely, it could be bacterial infection, it could be a fungal infection or what have you. That is enough to shoot the sugar up. Sugar goes out of control. Just because the sugar goes out of control, you treat it with insulin doesn't necessarily mean the patient is going to require insulin for life. You don't know that. You just treat the patient acutely with insulin, and I'll show you how to do that. Bring the sugar down to a normal level, and before the patient goes home, you switch them to an oral agent for a couple of days. You check the blood sugar 2-3 times a day when in the hospital to see if the oral agent is still working. If it's working, that's what they're going to go home with. Okay? So you have to understand, this is complicated stuff. There's nothing easy about clinical medicine, and it is not a science. It is an art form based on science. You must know the scientific data. Then you have got to understand the art of clinical medicine. You may be the most brilliant doctor in the world in terms of scientific knowledge, and yet you can't do anything good at the bedside because you don't know the art. You're not talented in that form. You're talented in other form. And I'm serious. Look at the title of this book, The Art and Practice of Modern Clinical Medicine. It's an art form. Clinical medicine is an art form based on science. You have to cut this and cut that, do a little bit of this, a little bit of that, in order to treat the patient properly. If you can't do that, please get somebody else who knows how to do it, because you got a sick patient at the bedside. They need a master clinician at the bedside to get that patient through the situation. And frequently, it's not just the reason that the patient shows up in the hospital that's going to doom the patient. It's other complications that are developing, and it takes the person with an incredible clinical mind to not only foresee all these complications. You can't constantly reacting to things. You have to proactively do things. You have to proactively do things. I got a patient admitted last week to a hospital that I wouldn't name. I got this silly phone call from a pharmacist questioning the fact that this patient blood urea nitrogen was 29, and I have the nerve, this patient is bleeding, to be giving this patient a medication called desmopressin to stop the bleeding because the patient was taking an NSAID. Who dared this person to ask the question, and he or she doesn't know anything about clinical medicine? Well, I had to answer it. But I said to her, I will answer your question if you promise you want to learn something. Telling me sometimes the patient has kidney insufficiency. I said, you got to be kidding me. This is not the mechanism. If the kidney fails, yes, when the kidney fails, the quality of the platelets is so bad, the patient can bleed. How are you going to tell me a BUN of 29, the normal is up to 20? You can't make this up. I got a phone call in the middle of the weekend, and I had to be so nice and so polite to this person, not to accuse her of being arrogant. Can you imagine that? So it turns out that if I were to tell you what was the patient BUN this morning before I got here, 9. How about that, okay? Because the mechanism is that when your kidney fails, there's a whole series of breakdown product of protein that the kidney cannot get rid of because it failed. cannot get rid of them in the urine. So all this breakdown protein pile up on top of the platelet. The platelet becomes qualitatively abnormal. That's what she was trying to talk about. But the kidney didn't fail. BUN of 29 is not a kidney failure. Kidney failure is when your BUN is 90, 95, 85, like your creatinine is 7. God knows what, okay? Suppose didn't have the knowledge to back this person off and give the person that was bleeding the desmopressin, because there's no way you're going to turn off the effect of that NSAID on somebody who's bleeding unless you have enough knowledge to give the desmopressin to raise the factor 8 von Willebrand to stop the bleeding within an hour and a half. That person, hematocrit was 23%, the hemoglobin was 7, and I'm being questioned. Can you imagine? After 47 years of practice, and I had to answer. You can't make this up. And this morning the person's BUN was 9, which means, in fact, what was going on, this particular patient was dumping blood into the bowel, or he or she may have been transiently hypotensive that can cause your BUN to go up, or the person was dehydrated. Suppose I didn't have the knowledge to back this person off and give the by the way, the hematocrit in question, the hematocrit in question is now about 36% because I stopped the bleeding. And I'm being questioned. And the individual had no interest in learning. None. No interest in learning and questioning me. There are 19% of the 185,000 physicians in this country who are full professors. Very few of them have this color. And I have 2 full professors. And this young person was questioning me in an acute setting. My patient is dying. And I had to answer this silly question. Okay? You can't make this up. In a hospital right here in White Plains last weekend. All this stuff that I'm telling you is stuff that I am experiencing every day. Moi, one of the leading doctors in the country and in the world, I had to answer this silly question in the middle of the night from someone who doesn't know what she was talking about. And guess what happened? The BUN now is 9. It was 29 last Sunday. And I was questioned. Okay? It's every day I'm dealing with this nonsense. And if I don't answer the question very politely, to try to explain politely, then I'm going to be reported for being abusive to someone. In the meantime, I'm under intense stress trying to save somebody's life who's bleeding. There's a very few medical emergency other than an acute heart attack or somebody who can't breathe because of pneumonia or pulmonary edema that is more crucial than acute bleeding. At my level. Okay? So, therefore, then you have got to understand clinical medicine, the art form. So when somebody shows up with sugar that is elevated, you're going to treat them with insulin to bring it down. Then you try them again on oral agent. If they respond to the oral agent, the problem is solved. You keep them on it. So now insulin, this incredible, fantastic hormone that we cannot survive without. And you have to understand there are several insulin in the market. And you can't make this up. I've been in private practice for 42 years. I have never used any other insulin than NPH, long-acting insulin, and regular insulin. 42 years, altogether 47 years of practice. I can't remember whether when I was in training that or the attending that was supervising me may have used something other than NPH, and the patient that I was taking care of, I don't recall. But moi, only NPH. And never, not a single time, my hand on the Bible that I have been in practice for 42 years, I have ever had to call an endocrinologist to help me manage a patient with diabetes. Let me repeat that, 42 years of practice, not a single time. In fact, I have never called an endocrinologist to help me with anything at all in a hospital setting. I have referred a few patients to endocrinologists on the outside for some other bizarre, complicated stuff for medical legal reasons, blah, 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 blah. Okay. But never in a hospital setting have I ever once called for an endocrine consult. Always manage everything myself, by myself, at the bedside, using my knowledge, okay? So, there are a lot of insulin out there. The list is quite long. I'm not going to bore you with all of it. I've copied the list, so my God, it is long, okay? And there's all this new stuff out there. You just name them. I have to know them because, as I said, I'm a teacher and I have to know all this stuff, write about it. But in my mind, only thing that you really need to manage a patient acutely who's got hyperglycemia, a whole host of other issues that I'm going to outline to you, is basically regular insulin and NPH. What are the problems? Well, hyperglycemia, sugar very, very high. You got to use either NPH, regular insulin, to bring it down. Regular insulin first to bring it down, either subcutaneously or intravenously to bring the sugar down. Then you switch the patient to long-acting insulin. Regular insulin kicked in half hour, and it's finished in 4 hours. Long-acting insulin kicked in somewhere around 6 to 8 hours and end up some 24 hours later, okay, NPH. You could manage the two together. The patient can be getting both depending on the circumstances, okay? And then if the patient, of course, comes in with, just to treat the hyperglycemia itself, but there are other conditions that are even more deadly than the hyperglycemia. I'll name them to you. Diabetic ketoacidosis, non-ketotic hyperglycemic coma, non-ketotic hyperglycemic coma. The patient's blood sugar is so high, 1,500, 2,000, and he or she didn't realize they urinate so much they become so dehydrated they went into coma. Non-ketotic hyperglycemic coma, diabetic ketoacidosis, severe hypoglycemia. Those are the danger in the acute diabetic treatment. Hypoglycemia, diabetic ketoacidosis, non-ketotic hyperglycemic coma. You must recognize this within moments, minutes, or else your patient will not survive. I'm going to stop here. Next week, I'll begin to talk about all these complicated diabetic forms. Until such then, keep watching the show. Dr. Alcena saying so long and bye-bye.